Hello, everyone. This is Alex again with the Tulane School of Medicine Pathologist Assistant Program. And today I'm going to talk to you about endometriosis. So, endometriosis, what is the confusion? I chose this topic because I felt like it was a topic that doesn't get a lot of attention. And generally, I feel like females are very misunderstood by not only males, but just everybody's just confused about what is considered normal period pain and normal ovulation pain or normal pelvic pain. And is it normal? And does everybody go through this, or when is it considered not normal? So I just wanted to cover the topic, and also I wanted to thank all of the patients and people that reached out to me that suffer with this condition and wanted their stories to be heard. I had a really positive expression from all of these people that really wanted me to talk about this, and I appreciate them sending in their stories, their photos, and everything that I was able to use to make this presentation possible. So thank you. So let's get started. A little bit about female pelvic anatomy, which I'm sure everybody knows, but we're going to go over it. We have a uterus, a cervix, two ovaries, two fallopian tubes, the vagina or vaginal canal, and then externally we have the clitoris, the labia majora, and the labia minora. So the uterus, as we know, is used to primarily be a womb for a fetus. The cervix here at the cervical os is where a baby would then exit through the vaginal canal out through the vagina. The fallopian tubes here are used to pick up the ovulated egg from the ovary, and sperm that would then enter the vagina and come up through the fallopian tube. Here around the ampulla is where fertilization would occur, and then the embryo would be implanted somewhere here in the endometrium. So now that we got that down, oops. What is endometriosis? So endometriosis is when we have endometrial tissue, which should be staying right here, nice and cozy inside this kind of triangular portion of the uterus. It's whenever it decides to leave for some reason and get outside of the uterus. So the presence of endometrial tissue, stroma, or glands outside of the uterus can impact approximately 1 in 10 women, and these implants can cause varying symptoms based on where they're located. So how does this happen? So there's a lot of, I guess there's a lot of talk and theories out there. One of the oldest theories is retrograde menstruation. So whenever you have menstruation, all of the endometrial tissue that's supposed to be sloughing off right here and coming out of the vaginal canal potentially could go retrograde back out through the fallopian tube and into the pelvic cavity. This can cause a lot of inflammation. This can cause an inflammatory or cytokine response from the body and can cause all kind of hectic stuff. The theory is a little bit less accepted as of late. Considering 70 to 85% of women have this happen in some form, and they don't necessarily have endometriosis. So some other options that have been put out there as far as theories are number 2, metaplasia. So residual cells from the Wolffian or Müllerian ducts could potentially change to endometrial tissue by metaplasia upon estrogen stimulation. So, of course, hormones, I don't really think I need to go over that. We all know hormones are crazy, and hormones will just pretty much make anything do anything. Fetal development. So, this was one during a lot of fetal autopsies, they started to find ectopic endometrial tissue, which kind of signaled the thought of defects in organogenesis right at the point of the fetus developing, and that it's not necessarily something that is always occurring later on in life. It could be something that's just starting at the beginning of the life, and we just never really knew it. And then direct implantation. So for women who have undergone abdominal surgeries, specifically C-sections, I'm sure you can imagine that if you cut the uterus right here to get baby out, that some of this endometrial tissue could then seed out into the pelvic cavity. So, what are the symptoms? There's a lot and they vary. And again, the symptoms and how much a woman hurts or doesn't hurt has no association with the grade of disease. But severe menstrual pain is one. Not all women have this. Not all women have any of these, or some women have none of these, and they just happen to go in and find really bad endometriosis. Again, this is not a all fits, one fits all or all fits one category situation. But if you're having menstrual cramps that are debilitating and or you notice that they're changing, maybe when you were a teenager they weren't like this, but now you're 30 years old and it's really painful for you, it's a conversation that should be had with your OB. Pelvic or abdominal pain that's not associated with the menstrual cycle. So if you're out of that, 1 to 2 day ovulation cycle and you're out of that 5 to 7 day menstrual cycle and you're still having pelvic or abdominal pain, that is a conversation to definitely have with your primary care physician or gynecologist, because that just signals that something's not the way it should be. Pelvic fullness. So a lot of patients that I talked to that had pelvic adhesions mentioned pelvic fullness, as well as down here, this tugging feeling. So you can imagine if your organs are kind of all adhered to one another, that whenever you make certain movements, that would make it feel like someone is pulling on something when they shouldn't be. Lower back or leg pain related to sciatica. So some patients that had endo deposits either on their lumbar or sacral plexus or near the sciatic nerve would potentially experience this just burning buttock pain that radiates down the back of their leg all the way almost down to their foot. Pain during sex. So this was actually a really big topic. So the frequency that it occurs in patients with endometriosis is very high. And I found that the topic of deep penetration sex pain was um, just talked about a lot in this community. And the patients that had endometriosis near both of those cul-de-sacs, so the vesicouterine pouch or anterior cul-de-sac, or the pouch of Douglas posterior cul-de-sac, which I'll get into, had really bad painful sexual intercourse. Painful bowel movements or urination. So you can imagine if you have endometriosis deposits that are on the sigmoid colon or the rectum and you're trying to defecate, how that could potentially land you with some severe shooting rectal pains, or sometimes just maybe not even rectal pain and just having change in bowel habits like diarrhea or constipation. I think it's pretty accepted by women that usually when they're on their period, they have kind of wonky bowel habits anyways. But if you're noticing that your bowel habits are severely changing or you're outside of your um, period or ovulation cycle and the bowel habits are starting to do crazy things, it's worth a conversation. Also, if you have endo deposits on the bladder, that could cause pain with urination, either through relaxing the bladder or whenever the bladder is full and it's distended. The endobelly, I have some photos of this. It's pretty interesting. But if you think about it, you have endometrial tissue that's outside of the pelvic cavity. Upon hormonal stimulation, it's bleeding and it's, doing, it's causing this inflammatory response within the pelvic cavity that can't really go anywhere. It would cause, you know, a, a lot of, I guess, inflammation in the area, and these patients, their bellies just get so big and very uncomfortable. Infertility, so if the endometrial deposits are near the ovary, either on the ovary, in the ovary, so if they're inside the ovary, it's usually referred to as a chocolate cyst, which I'll get into, or if they're perhaps blocking the fallopian tube. All of these things can really affect the ovum from either releasing out of the ovary or being picked up by the fallopian tube. And then suprapubic pain or vulvodynia. So if there are implants that are near either the round ligament or inside of the inguinal canal. The Both of those things then go on to attach to the mons pubis area and the labia majora. So you could have just like this dull aching pain near the anterior portion of the pubic bone. So again, the locations found, which I kind of just, spewed out to you, but it's kind of all typed up here. Pelvic endometriosis is typically organ structures closest to the uterus. So those fallopian tubes, the ovaries, and the ligament that, holds the ovary up, the ovarian ligament, suspensory ligament, round ligament, broad ligament, the pouch of Douglas. So that is, again, this area right here. So that's the posterior portion of the uterus and the anterior portion of the rectum. It's just like a little, I don't know, a great place for fluid and things to collect in. There you go. The vesicouterine pouch, so that's going to be the same space, but on this side. So that's going to be the posterior portion of the bladder up against the anterior portion of the uterus. And then extrapelvic endometriosis, so that would be things like the bladder, ureters, in the urinary system. And then for the GI system, sigmoid colon, I think that's the most common site for GI, and then rectum, ileum, appendix, and cecum. There are a lot of other locations listed here. They're not as common, especially diaphragm, belly button, the inguinal canals, and sacral nerves, but it's worth a mention just so people can realize that, again, this is not a condition that is just related to painful periods. It is physically a pathologic change of tissue that is really influencing an inflammatory and chronic illness response within these patients. So again, here we have the broad ligament of the uterus. So it's kind of cut out on this side, but it's all this yellow right here. And that is an extension of the peritoneum from the lateral wall of the uterus here and going over to the lateral wall of the pelvis. So it pretty much just anchors the uterus to the sides of the pelvis. It also encloses the fallopian tubes, and this little area here is referred to as the mesometrium. So there's iliac vessels, there's the round ligament in there, and then up here, at the hilum, there's the mesovarium, and so that is going to surround the neurovascular supply of the ovary. And then up here, it's referred to as the mesosalpinx. So that is the broad ligament area that is surrounding the fallopian tube. And then you have, I don't think it's in this photo. No, I don't. Oh, here it is. The suspensory ligament holds the uterus to the pelvic floor. The round ligament travels through the inguinal canal to then attach to the labia majora. I do not see round ligament on here. And I wanted to put some real photos in just because, cartoon photos can only do so much. And I really thank our program director of our program for providing these really great photos to not only us, but that we have an Instagram page. She has an Instagram page at Passion for Pathology. Also, we have an Instagram page, Two Lane Pathicist, so that people really can see real patient organs and photos and kind of put those things together with things that they might find in a cartoon form. So looking here at an anterior view, so this would be looking at the patient from the front side, you have the bladder and you have this like perivesicular peritoneal covering over it, like this fat covering. And then here, kind of like this area right here, that would be that vesicouterine pouch. So again, a spot where endo could, just kind of sit nice and happily right here. And then we have the uterus. So this is the top of it, the fundus, rectum back here. And then you can't see the area, but that little space between the uterus and the rectum would be the pouch of Douglas, which is also a common space for endo to hide at and has a lot of correlation with deep penetration pain with sex. And then you have your fallopian tubes with the fimbriated end over here to catch any eggs that are coming from ovary. And then again, that round ligament, that is going to come and go through the inguinal canal and is going to attach onto the labia majora and mons pubis area, if you can imagine like the pubic bone being right here in the front of the patient. And then up here is a superior view. So this, if you're getting a diagnostic laparoscopy, this is the view that your surgeon would be looking into your pelvic cavity from. So like looking down into the pelvic cavity. You have the fundus of the uterus here. Again, now you can see that pouch of Douglas. You can see how it's just a great little space for all kinds of things to collect in. Rectum, bladder, vesicouterine pouch. Again, now from a posterior view, so you can see a little bit of that bladder up here, but it's mostly that fat covering on this side. Ovaries, they're actually quite large. Fimbriated ends of the fallopian tube down here, fallopian tube, uterus, cervix, pouch of Douglas. It's kind of hard to see the fallopian tube on this side, but you get the picture. And a lot of people tend to imagine that your uterus is just kind of like floating in your pelvic cavity. You don't really think about all this other stuff that really is there anchoring it down. But the problem with that, with endometriosis, is this is just a great little spot for all of these endometrial implants to attach onto. And we'll see that later. So I'll step off my high horse on that. Diagnostic laparoscopy. So this is the standard to diagnose, which is kind of sad in a way that patients have to undergo surgery in order to get a diagnosis of this. There's no good blood test. There's no good imaging for the most part. Most of these patients will undergo an ultrasound prior to undergoing the procedure, just so their surgeon can rule out any, any other surprises. Like they want to make sure they're not going to find any other surprises while there. So the ultrasound is mostly to see if there's maybe fibroids or some cysts or, a tumor or anything that a surgeon might want to know up front before going in. The pelvic ultrasound, like I said, does not pick up endometrial lesions for the most part, or really any adhesions, but it could pick up some of those things before a surgeon gets in there, like cysts, fibroids, or abnormalities. Perhaps like if a fallopian tube is twisted on something. New evidence does show that having an MRI could pick up deep infiltrating endometriosis, although not all surgeons are, willing to give everybody an MRI prior to having a surgical procedure. So that's not really standard of care. And I think that it would only come about if a surgeon really suspected very deep infiltrating endometriosis, or the patient was perhaps getting an MRI for something completely unrelated. The gold standard is to excise the tissue and to send it to pathology rather than ablating and burning it. That just seems like common sense. If you ablate it and you burn it, you really don't know what you're ablating or burning. So if you excise it and you send it to pathology, you can get a histologic confirmation of, yes, this is endometrial tissue where it shouldn't be. And I think overall, it's just better for the patient. And I'd like to say also that many lesions may not be that obvious. And so if you, by taking it out and sending it to pathology, that really could make the difference from a patient going back home with a, no, you do not have this condition, versus we didn't think you had it, but it was found on histology. And I just think that's a great thing that us as pathologist assistants and pathologists in the field can assist with. So identifying lesions by color, typically they're thought as black or blue and a powder burn and puckered appearance. However, they can also present as clear vesicles, brown vesicles, yellow-brown patches, red polypoid lesions, white scars, deep nodules, and peritoneal pockets. And this is where it becomes really important to pick a surgeon or make sure your OB is very well educated in this condition, because who wants to really wait 4 to 11 years to, finally be at the point where they're going to get a diagnostic lab, and then they have a diagnostic lab with someone who perhaps does not fully understand the condition, or perhaps does not know how the condition can present in all of these different fashions. That is just a waste of the patient's time, and it's really sad for some of these women who have waited so long to get this done, and they feel like they're finally, going to get answers, and then perhaps they go home and they're just told, we didn't see anything, and they didn't take a biopsy, and these people go back home and they're in pain again. So just keep that in mind. Research has showed that the black lesions are the easiest to see and the easiest to document. However, those subtle forms, like those clear, tan, maybe like pinkish red ones, can be more active, even though they're not as maybe visible to the surgeon. Biopsies of the peritoneum can yield that pathologic confirmation, especially for hidden lesions that may be in peritoneal pockets or hiding behind adhesions and scar tissue. And we'll see that with some of the photos, that just how small some of these lesions are. They're micrometers. The active lesions are typically thought as the red ones, but not necessarily all the time. Um, and then the white lesions are typically thought as old fibrotic lesions. Endometriosis is most commonly missed whenever it's obscured by adhesions, deep fibrosis, leiomyomatas or leiomyomas, functional cysts, and little carbon deposits. So the types of endo that can be found within a patient vary, but there's three main types in that they're superficial. So this is non-invasive peritoneal implants that can present in a wide spectrum depending on the life cycle of the lesion. So that's kind of back to, the white ones are fibrotic, the red ones are kind of active. So these can really vary in how they present. There are cystic lesions, and so I'll get into these. They're commonly called chocolate cysts just because it's whenever endometrial tissue gets into the ovary, and then it just makes this reddish brown cystic lesion. And I have some photos of that. And then deep infiltrating lesions, or DIE, this is the type of endo that I was saying can be sometimes diagnosed on MRI because the endometriosis actually infiltrates into the layer of tissue where it is attached. So if it's on the sigmoid colon, it could potentially get actually into the colon, and those patients may need a colon resection. So it's very serious. The location prevalence. So peritoneal implants are commonly seen in those ligaments, again, in that pouch of Douglas and on the pelvic sidewalls. However, GI involvement can happen in it's a pretty big varying gap here, but 3 to 37%, with the sigmoid colon being the most common. Most lesions are confined to that serosal layer, but they can infiltrate deeper and get inside of the colon. Deep lesions will alter bowel function. Some patients who have lesions that are actually getting into the colon will have rectal bleeding, they have severe rectal pain, they have all kinds of changes in habits, and they could potentially, be diagnosed with an IBS or an IBD for a really long time until someone comes along and thinks, light bulb, maybe it's endometriosis that has gotten into colon tissue. And then genitourinary involvement in 1 to 2% of cases. And if it's involving the ureter, I mean, your ureter is just so tiny and so thin that if there is any compression on the ureter, you could have this silent obstructive uropathy, which can in fact lead to renal failure. So again, hopefully I'm getting the point across that endometriosis is not just painful periods. It can really, really damage a patient's internal pelvic organs, and it can really cause them just this chronic pain. And, they're going back and forth with their doctors. They have anxiety. They have, thoughts of, am I crazy? Like, am I really experiencing this? And this is, all of the stuff that was relayed to me by a lot of the people who shared their stories with me. So getting on to the lesions, um, those dark lesions that I was talking about. So this is kind of like that brown vesicular. This is kind of like that dark, puckered, black, almost like burnt look. Over here, this is more like a black blue, I guess you could say. And, some of them are really subtle. You might not notice it. These right here, not that noticeable. So it really depends on who's doing the procedure. The white lesions, sometimes they can be white and start to form the brown lesion within it. So this might be an old endo, the white might be an old endo lesion that's now turned fibrotic, like a scar, and then now we have this like new deposit going on here. Same thing going over here. And then this patient that sent me her stuff, she had stage 4 uh, deep infiltrating endometriosis. You could see her surgeon wrote that up here under her left ovary near her ureter. She also had it on her left posterior cul-de-sac, so that's that pouch of Douglas, and on her right uterosacral ligament. So her story basically, she noticed her symptoms getting worse after her second child. She had a C-section. Her chief complaint was sharp stabbing pains, almost like a dagger near her left ovary. She had always had painful periods, but after her second child, something was just different and very wrong. So she was directed to try birth control. She did that for a while. She complained to her doctor more. She went in for a diagnostic lab, and it was seen that she has endo. It still took her a really long time to get the correct management of endo, which was initially she had ablation, and then she found an endometriosis specialist who could then do an actual excisional surgery. She had other things going on besides endo. She also had adenomyosis. She had issues with her C-section scar, and she had pelvic floor dysfunction. So she went ahead with a hysterectomy, but I believe she spared her ovaries. And again, she had that deep infiltrating endometriosis stage 4. So here are some more pictures from her, again, on the left uterosacral ligament, and this little bitty tiny deposit on the left bladder. So like I said, it honestly, since this is a condition that is mostly diagnosed by diagnostic lab, it's very, very important to make sure that the person who's doing it knows what they're doing. And then these are just some pictures of adhesions. I thought that was important to go by because some patients, they might go in and ablate these adhesions, but you got to figure, if this is a little bitty tiny endo deposit, that could for sure be hiding all up in here. So ablating it doesn't really do anybody any justice because it just gets burned off. Send the tissue to pathology, do a histologic examination of the tissue. And again, these adhesions, like I'd said earlier, can give that tugging, pulling, or weighing down feeling. And then here's a photo of uterus and bladder fused together. So it's important to realize how much pain these patients really can go through and how much their pelvic anatomy can be distorted by this. So going into those cystic lesions, these are called endometriomas or chocolate cysts. The cysts form from endometrial tissue getting inside of the ovary. It's filled with dark reddish brown fluid, and they can be pretty small at 0.75 cm or can get as large as 8 centimeters in size. And you can imagine, 8 centimeters is like a grapefruit. If that's growing inside your ovary, that's not really going to be very comfortable. And it's also not going to be very conducive for an egg to want to be fertilized. Not only will it cause trouble with the egg physically getting out of the ovary, but you got to figure if you got this 8 centimeter endometrioma and your fallopian tube is supposed to be right there on top of the uterus, but now it's pushed up 8 centimeters, even if the egg does get out, it's really not going to have as easy of a journey to get to the fallopian tube. So patients with these chocolate cysts have a larger impact on their fertility and ovarian function, just because the cyst can destroy much of the healthy ovarian tissue. So here I have a picture of, down here on the bottom left, a ruptured chocolate cyst, and also the patient had some ablated endo. So this is after it's burned off by the tool that they use in the laparoscopic procedure. So they're ablating it. And then here again, yes, the patient relayed to me that she did have a ruptured cyst, but she also had what was termed as black endo, and you can kind of see it kind of everywhere. And then this is what I wanted to come across to everybody about that endo belly. So a lot of these patients look pregnant, right? But, well, I'll let you guess for a second. Which patient is actually pregnant? And the answer is only this patient right here. She was 9 months pregnant, I believe, in this photo. And then she took this photo as comparison, which she's not pregnant at all, just to come across to everybody of how much bloat can really go on in these patients' bellies. And it's really sad because I'm sure people ask them all the time, like, oh, are you pregnant? Are you expecting? When are you due? And that's demoralizing if you're not pregnant. I mean, nobody wants to hear that. So I just wanted to put that out there. Don't ask somebody about their pregnancy if you don't know if they're pregnant. Okay, so staging. The stage of endometriosis does not necessarily reflect the level of pain experienced. For example, it's possible for a woman in stage 1 to be in a tremendous amount of pain, while a woman in stage 4 could be completely asymptomatic. And so here, stage 1, minimal. These are few superficial implants, just a little bit of scar tissue, mostly on peritoneal and pelvic organs. So you're not really getting out of that pelvic cavity. You're not, getting to extra pelvic sites. It's still in those organs that are pretty close to the uterus, and it's not infiltrating into anything. Stage 2, mild. Implants may be a little bit deeper, could have some scar tissue formation. Stage 3, moderate. All of the above, but now have some filmy adhesions, some scar tissue, maybe some small cysts forming on one or both ovaries. And then stage 4, severe. This is what is termed as deep infiltrating endometriosis, or DIE. So all of the above, but now maybe dense adhesions, large cyst formation on one or both of the ovaries. And again, that cul-de-sac obliteration is referring to the infiltration of tissue lining the posterior uterus and the rectum. That's the pouch of Douglas, or potentially the anterior cul-de-sac, which is between the bladder and the uterus. And then probably the worst outcome and the most painful from what I gathered is frozen pelvis, which is deep infiltrating endometriosis that attaches ligaments, nerves, muscles, pelvic sidewall, parts of the GU and GI system, pretty much just like cements it all together. And these patients' pelvic cavity is literally like, it's just stuck like glue, and they just can't even move. It hurts to walk. And I just think that's crazy. So through all of this, I, gathered a lot of things that patients said about how they feel, and I thought it was important to read a few of them off to you all, so I will. So this was specific to endo and how they feel. So I feel like my insides are encased in barbed wire, especially when I try to move. I feel like someone has jammed a hot poker inside of me. I had pain so extreme, I literally couldn't stand up straight, and I had to slide my feet to walk. Intolerable pelvic pain. I couldn't stand up straight during my ovulation days, and periods started to become unbearable. I knew something was wrong. I stood up from sitting in my car, and I felt like my ovaries were tied to the seat. Yes, like a hot needle rammed up my rectum that made me jump a mile. I don't have any pain, and I have stage 4. Feels like my bladder is zapping me while I relax to pee. I had endo stage 4 and rarely have pain. I didn't get diagnosed until I was 39 because my symptoms didn't really fit with what many women experience. And then these quotes were specific to pain, just because I thought it was important. It seems like a lot of women think that pain during sex is normal and that it should just be accepted, and we should just lay there and take it. But reading these was really sad, and I don't know, take it as you will, but every time I have sex, I am holding back the tears. Burning discomfort inside of my vagina for the rest of the night. Feels like my partner is hitting a wall while having sex. Sharp stabbing pains during it and bad cramping afterwards. Feels like pulling out a dry tampon during the act. Usually it feels like I'm being penetrated with sandpaper, but during ovulation, it's sharp stabbing pains. I don't have much pain during sex, but about 20 minutes after, a horrible ache starts in my pelvis. Sharp pain with penetration, like a knife or scissors. Feels like I'm being penetrated with a knife. It takes all my focus to relax my pelvic floor. It's hard to even pretend I enjoy sex at all. Pelvic floor physical therapy is a game changer, though. So, out of all the people that sent me so many things, it was hard to really choose who story to kind of present, I guess. But I just went with this one because, again, I don't want to present like the worst case, but I guess I just want this to come across that this is not just painful periods. So case study, stage 4, rectovaginal endo. The patient had symptoms of diarrhea, fatigue, nausea, constipation, shooting rectal pain, and hip and back pain, which probably then led a PCP or someone to do, blood work on them. And she had elevated CA-125 markers, which usually is an indication, it's a cancer marker. So she saw her gynecologist, who visualized her cervix and saw a bunch of cervical nodules, which then triggered her getting a colposcopy and a punch biopsy of her cervix. The histologic confirmation was that it was endometriosis. She shouldn't really have endometrial tissue on your cervix. She underwent surgery, which ended up going way more or way longer than it should have because they had to do a bowel resection. They took 6 centimeters of her bowel. She had endo within her sigmoid colon. Again, that deep infiltrating endometriosis. She had to get a partial cystectomy, which is removal of a portion of your bladder. She had a 5 centimeter endometrial nodule on there. And then, of course, she had the hysterectomy because that cervix had so many ulcerated nodules on it. But all in all, this is a lot of symptoms, and there are a lot of other organs going on in the pelvic cavity, and it might not always be endo. So some other mimickers of endo are things like adenomyosis. So this is a condition where tissue that is lining the uterus then invades the muscle of the uterus. So you figure your endometrial tissue is right here, and endometriosis is whenever this tissue gets out of here. But adenomyosis is whenever the endometrial tissue then grows into the uterus this way. Interstitial cystitis, so this is a chronic condition causing bladder pressure, bladder pain, and sometimes pelvic pain. And usually they'll go in and I think it's called a cystoscope. They'll go in and visualize the bladder. And I think they can diagnose interstitial cystitis that way. Pelvic inflammatory disease. So this is usually an infection mostly caused by STDs like chlamydia and gonorrhea. So this causes just like a whole inflammatory response in this entire like pelvic cavity. Pelvic floor dysfunction. So women with pelvic floor disorders can experience chronic pelvic pain that can radiate to the groin, abdomen, and back. They also can have painful sexual intercourse, strong or frequent urge to urinate, urinary incontinence, vaginal burning, painful menstrual periods, and difficulty with defecation and constipation. So again, a lot of these conditions really start to intermix with one another. Pudendal neuralgia is a condition that causes pain, discomfort, or numbness in your pelvis or genitals. It happens when a major nerve in the lower body is damaged or irritated, and it can make it hard to use the bathroom, have sex, or sit down. And then lastly, this is unrelated to endo, but our colleagues at LSU had posted a story on their Facebook a few days ago, and it was about gender disparities in quality of care. And they were talking about how when men go to the doctor and complain of, pain with bowel habits, or pain if they have any issues with their sex life, or pain in their pelvic cavity or whatnot, they are viewed as brave, stoic, and manly. However, when women present and have sexual problems and pain associated either with menstruation or ovulation, or with neither, that there is this idea that they're emotional, hysterical, and complaining. So in 2019, the Journal of Obstetrics and Gynecology made a statement recognizing the clinical signs and addressing women's concerns with increased pelvic pain and changing bowel habits. Again, there's a delay of 4 to 11 years from symptom onset to diagnosis, just because of the variability of symptoms. Um, Endo should be approached as a chronic, systemic, and inflammatory disease that is heterogeneous. Not all patients are going to come with the same complaints, and these um, these complaints shouldn't be taken lightheartedly. The time has come to bridge disparities and to minimize delays in endometriosis diagnosis and treatment for the benefit of all women worldwide. So these are my references upon the many women who just were so great and reached out to me and emailed me and Facebook messaged me and texted me, and just were so happy to have someone talk about this condition and hopefully educate others on it. I'm sure I didn't do the greatest job, but hopefully the next time I present it and all the times after, we can add some more content to it and get the word out there and just make this something that people want to talk about and are comfortable with talking about. So thank you.